Hi everyone, I'm Ziad Khoueir. We are live from EPOMEC and we're lucky to have Kaweh Mansouri, Executive Vice President of the WGA, the biggest glaucoma society, coming straight from Lausanne, Switzerland, and Luís Pinto from the European Glaucoma Society, and coming to us from Lisbon, Portugal. How are you guys this morning?
Good morning.
Good morning.
All good?
Thank you.
How has it been so far at EPOMEC? Is it your first time here?
It is my first time at EPOMEC, yes, and I'm really astounded by the size of it. It's a huge meeting, uniting people from all over the region. It has a fantastic scientific program. It's very well organized, and all of that in this great city, which is Dubai.
Yeah, that's always amazing to be here. What about you, Luis?
Same. I think it's my first time here, actually, both in EPOMEC and Dubai. But it's the atmosphere. You feel that people are truly networking. The concept it's actually something new, which I haven't heard. We have all the subspecialties in the same room, fighting for their audience. It creates a more lively engagements, and people get more exposure to educational material.
Yeah,
It's a nice project.
that's quite unique. Let's go now to the glaucoma program. So, what are the main highlights of the glaucoma program? What's something that you enjoyed? Something new? Something maybe a bit more relevant to the region, or
I think you made a good. Someone made a good program. I think it was you to make a controversy sort of thing. So I think that what differentiated, I think, from other meetings, is that you get a more practical view. I mean, these are not glaucoma specialists that are listening. There are people who do glaucoma as part of their normal routine, and by trying to feed them, for instance, the controversy sessions, OCT versus gonio, combined versus isolated, things who are practical that they would use on Monday when they go back to their practices. I think that was very useful. You gather to a top-notch faculty, and to make sure that they would get not the discussion what's going to happen in 10 years, but something that they will use on Monday. And I think that's what kept the room full.
okay. What about you, Kaveh? As EVP of the WGA, seeing one of the probably the biggest ophthalmology meeting in the region, having a big glaucoma track. Is it something that you would like to see a bit more in other regions of the world?
Absolutely, you make a good point, Ziad. The World Glaucoma Association reunites the world's glaucoma societies, and it's important for WGA to make sure all voices are being heard, all viewpoints are being seen and represented in our events. And this is a big region here. You're talking about hundreds of millions of people who live in this region. And this meeting represents not only the Gulf region, it's a meeting that is representative of the Gulf region, it's representative of the Middle East and Northern Africa. And these are voices that are not necessarily always seen and heard in a European meeting or in a North American meeting, or even on a global scale, sometimes are underrepresented. Another observation which I had a chance to make here is to see, how young people are sometimes more represented in this meeting or this part of the world that they are in our classic, North and Western meetings. And there's a high representation also by female colleagues in very prominent positions on the podium, as heads of societies, as board members of regional societies, which people outside the region are not necessarily aware of. So this was something relatively new. This is a very interesting observation. And to come back to the glaucoma scientific program, which is the part that we took part in mostly, it's I can only echo what Luis said. What I appreciated was that different formats were tried here. I mean, we are in a region which is moving fast, which is reinventing or inventing some things new. And also in this meeting, you had, of course, you had the classic topics of interest in glaucoma, from mix to innovations to medical treatments to imaging advances and AI in imaging, but the format in which it was presented, and you were one of the scientific organizers, so it's also kudos to you, Ziad. A lot was experimented, from the classic debate to more innovative debate formats, and there was a lot of interaction between faculty on the podium and between faculty and audience, which is in any case what we as participants always enjoy most. My most memorable moments from any conferences are the discussions that took place at the end, because this is really where we learn more. And there was a lot of that, and more of that here at the EPOMEC. I would say that in some of the last meetings that I had the chance to attend.
Yeah, we have a wide variety of topics and formats. Like Kaweh and I were giving an OCT workshop this morning, and this is a EPOMEC tradition. In the mornings, we have, some workshops that are not actually basic, but it covers, OCT, visual field, gonioscopy, and it gives you the opportunity to interact, learn, go back to the basic, share tips and tricks. And this is, I think, one of the cool aspects about the this meeting. And then you have other formats like the debates and more cutting edge topics. So let's shift gears now and talk about your topics. What did you guys talk about during EPOMEC? Luís, did you talk about something EGS related, your work with AI? What did you cover this year?
Exactly those topics. I mean, but one of them is still going to be covered now. The guidelines came out this year in June. So
the
it's
EGS
the
guidelines.
EGS guidelines. It's one of the most downloadable products from the BGO. So it's something that resonates even outside Europe. So a lot of societies have either endorsed or commented, and from South America to the Middle East.
Yeah, you guys even have an Arabic version that is
Yes,
quite popular
right.
here in the Middle East, the European Glaucoma Society guidelines in Arabic.
And we'll try to do the same with the 6th edition. So
Okay,
it's,
that's cool.
We're already in the process of translating. It has been done already in French, in German, in Spanish, Portuguese, but Arabic would be next, because this is a big region. Most people here are excellent proficients in English, but we understand it the guidelines are very good for glaucoma specialists, but they're essentially meant for the person who just has contact every now and then with glaucoma and wants to have I will only open one book. I will only do this, then do the guidelines.
And you're going to talk about those guidelines today?
Yes.
Okay. And what's new in those guidelines? What's if you have to talk about three major concepts?
Topics. We now have a patient. I mean, there were novelties in the last 5 years. We edited one every 5 years. AI, because there is a lot of coverage and attention about what AI is doing. Patients Initiative, EGS has a patient organization under its umbrella, and we asked them to actually comment on all the clinical questions that we had.
So you have patient comments within the guidelines?
Yes. For instance, when you have, should you do an iridotomy on a patient with angle closure, you have the evidence, you have the level of recommendation from within clinicians, and then you have the patient's comment to that. For instance, in that comment, they would say, please explain the dysphotopsia or the long-term benefits. Please explain the process in due calm. And also have a chapter on what they would want you to focus when you approach them. As in, don't assume I know things. Take care.
That's interesting. That's a first.
It's the missing stakeholder that we've been always having. And if I had to do something, we integrated, of course, the new RCTs into from the ZAP to the analyst to the JITs.
So AI, patient perspective, and
the new RCTs. That will be the most. But I'll be talking about that for 7 minutes in the next future.
That's really interesting. What about you, Kaweh? What are your main topics here at EPOMEC?
One of the topics that I enjoyed speaking about and exchanging about is myopia and glaucoma. As you well know, myopia is increasing everywhere, especially high myopia is increasing fast everywhere in all the regions. And this is a major challenge for glaucoma. It not only increases, as you know, the prevalence of glaucoma is a main risk factor, but it poses diagnostic and treatment challenges in glaucoma. So there was a session where I spoke about this topic and we had good exchanges on that. And this topic is only going to get bigger in future years with the epidemic of myopia. And as populations age and myopic youngsters become myopic glaucoma suspects in the next decade. This is something where a lot more research has to happen. In the recent years, the research that used to start in Asia, be confined to some Asian centers, has now expanded to the US, and also in Europe, our colleagues are starting to look into the matter. I took this meeting also and my talks as an opportunity to advertise the next World Glaucoma Conference, because both Luís and I represent here not only ourselves as glaucoma specialists and scientists, but also the respective societies that we work for. So I did mention that the next World Glaucoma Conference, the 11th, will take place in 2017 in Kyoto, Japan.
Each one of you
And
has
of
an
course,
upcoming
it would
meeting.
be a missed opportunity if it would not be advertised. And we want to make sure to get high representation also from this region at our next meeting.
Yeah, tell me more about your upcoming meeting. Is it 2027?
27.
Where is it going to be?
It's going to be in Kyoto, Japan, right at the end of cherry blossom season. So it's a very nice season to visit this beautiful country. We will do it in collaboration with our Japanese colleagues, the Japanese Glaucoma Society, which is one of the biggest glaucoma societies worldwide. And it's an old society, a very active society. It's a country where a lot of glaucoma research happens. So it will be an opportunity to bring people together from the whole world in one location, and also to exchange with Japanese colleagues.
So this is the World Glaucoma Congress. Is it the biggest glaucoma meeting?
It is the biggest regular glaucoma meeting, yes. And it's the one glaucoma meeting that represents all voices and all viewpoints on glaucoma.
What about you, Luís? Tell us more, because your meeting is closer, right? It's
yes.
2026.
Really, I think it's a very good arrangement that it's not on the same years, because
It's for purpose.
It's for purpose, exactly, to make sure that, well, as a preparation or on its launch pad, we have the EGS meeting in Brussels in early June next year. So also using the same concept, we're trying to bring people together on Europe's capital, so to speak. Advocacy will be something, lobbying will be something, because we need to take all these stakeholders together. The main topic will be with a little help from our friends, because glaucoma care is becoming a little bit more complex. People live longer, they have diabetes, they've injected something, they have myopia, so we need to engage with the neuro-ophthalmology, the medical retina, the cornea people, because these people had LASIK. So most of our regular patients are not followed just by you if you're a glaucoma specialist. They will be followed by one or two more ophthalmologists. And this creates the problems of, well, even resources allocation, and most of us learning how you communicate with each other, because they just don't have glaucoma. They have probably something else. So it's a way to merge everything together in the same place in Europe.
That's really interesting. So we're really looking forward to those two meetings. I think those are going to be two major events in the next 2 years when it comes to the glaucoma committee. Are you getting some attendees that are non-glaucoma specialists, like comprehensive ophthalmologists, to those meetings?
It happens. I'm not sure if you want to. It happens a lot. I mean, we usually have roughly 3,000 people. Some of them are people after their early training that they want just to get a view on glaucoma, especially with all the glaucoma usually represents 20% of your practice, even if you're not a glaucoma specialist. So renovating drops, knowing what's new, knowing where to refer and what should they be asking for is part of our practice. We don't have the numbers split out like that, but I would say 30 to 40% of our people are general ophthalmologists.
What about the WGA?
I would also say, if we would not be doing our jobs correctly, if we made a meeting only for glaucoma specialists, one of the main purposes of the World Glaucoma Association is to increase education of glaucoma within ophthalmologists. So although our meeting is done by glaucoma specialists, it's a meeting for glaucoma specialists, for ophthalmologists with an interest in glaucoma, and for comprehensive ophthalmologists. Every ophthalmologist should be able to detect, diagnose glaucoma promptly, correctly, and even if you should not be comfortable treating and keeping these patients, at least referring them to a glaucoma specialist at the right time. So just as EGS, our meeting is intended to provide high-level glaucoma education, but for any ophthalmologist.
Okay, coming back to this meeting and our topics, I think both of you are world-renowned experts in the term of what we call minimally invasive bleb surgery. Those new devices that are not exactly like a trabeculectomy, but they try to give you, an efficacy that would be somewhere between a trabeculectomy and MIGS. Where do you see the MIBS landscape evolving in the next 5 years?
That's a very good question. There's several angles into that. It's On one hand, it takes less time from the surgeon, so it's very tempting. From the patient's perspective, recovery is probably faster, also tempting. The learning curve, I would say it's easier as well. So it depends on the volume. I think it will increase because of all this. Now, the costs will also be something important, and the long-term data. I think we were debating this a few days ago, is that if you keep doing MIBS, which is a great short and medium-term solution, but then we don't know in the future. So this will grow for all convenience, logistical reasons.
This will grow in terms of
Volume.
more surgeons doing those techniques or more products being available.
I would even say that I hope that it is experienced hands doing more surgeries.
Okay.
I don't necessarily mean that more people will be doing it, because if, as with anything, cardiologists do this, you can only do a catheterism if you do 200 of them per year. Otherwise, you cannot guarantee good quality. So the risk is there if you do 5 of these MIGs per semester or 10 per year. I mean, you might feel you're doing a good job, but maybe someone else could be doing it if you do it 50 or 60 or 100. So I think it will grow because you will be faster and better at doing it. But I would not encourage, if you're going to do something 2 or 3, please refer. So I don't think the market will grow in the number of surgeons doing it. I think it will grow in volume because it gets shifted from other surgeries.
How do you see this aspect of glaucoma care evolving? You know, when MIGS started, you know, we had a plethora of, you know, implants techniques, but in the area of MIBS, we're still limited to 2 devices, actually, the Zen and the PreserFlow microshunt. How do you see the tendency in the next 5 years? Is it gonna slow down, die away, or do you think it's a MIGS, not the MIBS sector is gonna grow and change the way we manage our
I
patients?
think we are reaching now, we have reached maturation. It's settling now. We are getting more familiar with the 2 devices in question. For MIBS, we have now 5-year data published. We will soon be having 10-year data published. The first 10-year studies will be published soon. So we know much more than we did a few years ago. We know enough to say that they have their place. They are going to stay here. They have their role. I think, for example, when it comes to combined cataract filtering surgery, MIBS, in my opinion, are superior to classic filtering, which I do not like to combine with cataract. At the same time, I would caution any and every center to be switching completely to MIBS, giving up on classic filtering, be it deep sclerectomy or trabeculectomy. These remain important, will remain important for the foreseeable future. The danger for centers who switch completely is that, you know, the trainees will not learn them, will not be familiar,
Absolutely.
and they will face major problems if they only train with MIBS and do not practice sufficiently and become comfortable sufficiently with classic filtering surgery that has its place and will keep its place for at least for 1 generation.
Absolutely.
This is just to comment. I think that's a very good point, because in the end, if you don't keep yourself having volume, you will get poor results. So imagine if you start shifting in less trabeculectomies, the less trabeculectomies you do, the more complications you will have, and the more chances you want to rotate completely to the ones who appear safety. So it's a vicious circle.
It's a vicious circle, unfortunately.
The less you want to do, the more risky it becomes. So it is a very valid point.
So the last topic that I want to talk about with you is that, you know, the upcoming trends in glaucoma. What's the main trend that you identify for the next decades in terms of, you know, glaucoma management and glaucoma research?
I think AI will change the way we work.
AI,
because imagine, for instance, if you think 10 years in the future, you're just thinking, will we become bigger or not? But very likely we won't use 5 devices. Probably going to use 1 device, let's say a fundus camera, and that will extrapolate how the visual field would look like. What's your risk of developing central vision loss in 10 years? So you may be doing a less exams. So all the patient circuit that usually stay 3 hours in our clinic doing OCT, visual field, etc., before they see you, all that risk assessment very likely is going to be outsourced. So if you start not to think as an added tool, but actually changing the workflow, it might change. I mean, we may do screening. We may just have patients doing 5 minutes in your
Telemedicine even.
telemedicine. So
Yeah.
I think it's not adding a tool, it's changing the way, it's going from horses to cars.
So for you, it's not a hype. It's basically a future trend that is here to
yes.
stay.
Same thing with your
Definitely
phone.
when
I
it
mean,
comes to glaucoma.
You have to imagine 5 years ago, your phones did not do half of what they did now. And now you can basically even with ChatGPT app it's changing the way you work.
Game changer. What about you, Kaweh?
It's hard to disagree with what you said. I don't think it's a hype. I think individual companies in AI may be a hype and may disappear, but the place of AI is definitely not a hype. It will change very quickly a lot of things we do. I think I wouldn't be able to say what the trends are in the next 10 years, aside from being related to AI. I think what will happen is surprises will happen because of AI. Changes will be accelerated with AI. And there are a lot of things that are happening in the background, research that are happening in smaller labs, in smaller startups that we don't even know of, and that would take much longer to come to a positive or negative result. But I think the integration of AI will accelerate dramatically the outcomes. And we will find in 3 years or in 4 years that we have a new protective or a new way of treating glaucoma beyond lowering IUP, based on things that are happening in the lab, but which will be accelerated by AI. I think that's going to be the next trend. Surprises are going to be next trend over the next 10 years in glaucoma that we cannot even think of. So I think it's going to be very interesting. It will be, we need to belt up because there will be ups and downs. We will need to be much more flexible to adjust as we had to in the past.
If I had just to mention the one caveat of this, the risk is that if you completely outsource the task and not train yourself manually or clinically, you won't be able to break the tie. Imagine what will be the role of the human in the clinic led with AI? You will be called in to, when the AI says, I'm not sure, you're going to be there to solve it. But that time you still need to be on your top toes to make sure you know how to break the tie. Because if you only start to say, okay, the AI says, okay, I won't know how to do it. So it is important for people in the clinical practice to still look at the optic nerve, not just trust OCT. They still need to know how to interpret the visual field because, okay, 90% of the job might be doing by the AI, but the 10% is going to be us, are the more challenging cases. So it's the time where you have to be even more experienced than you were before.
Yeah, this is something that we absolutely need to focus with our trainees, because those are the future glaucoma specialists who will be evolving or navigating into this into this world.
The comparator is the phaco. No one would know how to do an extracapsular. So the risk is there. You see a problem and you don't know how to solve it. You have to refer it to someone else.
Maybe an AI robot in the future will do our extra cap. Let's see. Let's see. Guys, it's always a pleasure chatting with you. Like, we learned a lot. Now we have some glaucoma sessions to attend. I hope you enjoy your day. I hope you enjoy EPOMEC, and I hope you enjoy Dubai. Thank you so much.
Thank you for the invitation.
Thank you, Ziad.
Thank you.